Let's pick up where we left off. We started to embark on a conversation on how to pragmatically approach hypernatremia. We've gone through steps 1 and 2, so I won't backtrack too much. Let's just delve into step 3. So after you get these important indices of water handling, you have to understand the factors that may alter these normal physiologic response to hypertonicity, if this is a case of hypernatremia. So let's then discuss those in some more detail. Urine osmolality is the first one that we're going to talk about. I didn't confirm that you guys can hear me who are virtually participating. Alvin, can you hear me?
Yes, I do.
Okay, thank you. All right, so again, urine osmolality should be concentrated in the face of hypertonicity. What are the conditions that can impair that? Well, of course, if I have inadequate ADH, that would be classically central DI. If I have a problem with response to ADH, so I would say impaired increase, this is kind of wordy, but impaired increase in water reclamation in response to ADH would be nephrogenic diabetes insipidus. CKD, we say that urine osmolality in patients with moderate to severe CKD is isostenuric, meaning it is neither that dilute nor concentrated. And so even though ADH may be sky high, a urine osmolality may be somewhere around 300 in a CKD patient. Resolving AKI, similar story. Chronic interstitial nephritis would be a scenario in which you might predict ADH responsiveness is impaired. And then, of course, if somebody's receiving a vasopressin antagonist of some sort. Okay. Now, the last one that would be an explanation for impaired response to an appropriate increase in ADH would be that the tonicity of the medulla, the interstitium, that drives water reclamation is less than what would be typical for somebody with a normal functioning kidney that is responding to ADH. Remember, we talked about how ADH increases medullary tonicity through enhancing the recycling of urea. So I'll just make that point once more, that urea transporters are also influenced by vasopressin. And that increase in medullary tonicity enhances water reclamation in addition to the increase in water conductance through aquaporins. So again, anything that impairs that medullary tonicity, hypertonicity, would also expectedly limit the amount of water reclamation that one can mount. So classically, the use of mannitol increases medullary blood flow, increasing or reducing the medullary tonicity. Okay, that is one mechanism by which mannitol enhances water excretion. We talked about another, remember? So going back to this figure, the number of osmotically active particles is an influence or influences water reclamation, right? If you have lots of osmotically active particles here, few here, water moves from higher concentration to lower concentration. But mannitol, if it is in the tubular lumen, that would retard the reabsorption of water. So mannitol is an osmotically active particle. It also results in an increase in medullary blood flow, decreasing the tonicity of the medulla. And so there's more than one mechanism whereby mannitol can impair water reclamation. Active loop diuretic therapy is another one that we should spend a little bit time on. About half of the tonicity in the medullary interstitium is contributed by urea. The other half is sodium and potassium salts. That concentration of sodium and potassium salt depends on an intact thick ascending limb transport mechanism. Okay. And we rationalize that that mechanism is driven by something we call countercurrent exchange. So let me just say as a overview statement that countercurrent exchange is a model of thick ascending limb transport and medullary tonicity increase that is not completely, that we don't have complete certainty is accurate, okay? But what we do know is that either through this countercurrent exchange or through some other physiologic process, sodium potassium 2 chloride transport is certainly important for creating that medullary hypertonicity. Okay, and so if you block this transporter through the use of loop diuretics, you would predictably reduce medullary tonicity. And if I reduce medullary tonicity, then I'm reducing water reclamation in the collecting duct. Okay, and so we expect that loop diuretics usually enhance water excretion. I have to choose my words carefully because that is not always the case. Certainly at your stage of training, I'm sure you've treated plenty of patients with loop diuretics and witnessed worsening hyponatremia, right? So there must be more complexity to it to explain your clinical experience where loop diuretics do not always elevate the serum sodium by enhancing water excretion, okay? So let's move on. We've covered urine osmolality. Again, attempting to understand the alteration of the normal response of water conservation to hypernatremia. We can move to other parameters that help us to elucidate the physiology at play in this particular patient. So you would expect that urine sodium would be low in an individual with low effective circulating volume. Okay, so in a patient whose ADH is high, it would be driven by hypertonicity itself, right? But it also would be expected to be driven by low effective circulating volume. So low urine sodium is going to be your biomarker for low effective circulating volume. Now, of course, there are modifiers of that normal response, and that might be because you have an impairment in aldosterone secretion through primary adrenal insufficiency. Primary adrenal insufficiency means adrenal glands are dysfunctional, right? This is not a problem with ACTH. This is a problem with the adrenal glands itself. One would predict both glucocorticoid and mineralocorticoid deficiency in that scenario. And that might be a scenario in which urine sodium is not maximally conserved. Okay. Much of this part of our conversation will be filling in knowledge that will be more relevant for the hyponatremic patient. So this is, let's say, an investment into a discussion that will take place in the future. So, just do absorb this so that when we come back to hyponatremia, we do not have to spend much time on this when we're talking about why somebody might be, in that case, reclaiming water inappropriately in the setting of hypotonicity. Okay, so let's continue this conversation. But again, it's mostly relevant for the hyponatremic. Impaired tubular response to antinatriuretic hormones would be captured by these clinical syndromes. You can see that they parallel some of these problems with normal response to ADH. So CKD, acute kidney injury, these are scenarios in which tubular dysfunction may inhibit the maximal conservation of sodium, even in the face of low effective circulating volume and high norepinephrine or angiotensin II levels. Okay. The chronic interstitial nephritis would be another scenario that one can imagine. And of course, if I'm actively being diuresed, right? If I have thiazide or loop diuretic therapy on board still, you may have somebody with high ADH and therefore high urine osmolality. The cause of that be low effective circulating volume, okay? But in that scenario, urine sodium is not low, as you would expect, because they have a natriuretic on board. Okay, so this would be a reason for confounding urine sodium as a biomarker of effective circulating volume. As you interpret dysnatremias, there really are two categories to summarize your urine sodium: low and not low. So don't think of it, I don't want to hear high urine sodiums. I just want to say, okay, it's a low urine sodium or it's not low. Okay, and that really is your primary reason for checking your urine sodium. It's not so much for calculating electrolyte-free water clearance. We've talked about how that can provide limited insights into what is going to happen to the patient because it's one-dimensional. It's only saying what is your kidney doing. It's really not taking into account what is the patient drinking, what are they eating. All of that is not captured by electrolyte-free water clearance. Your main reason for checking a urine sodium is a biomarker for circulating volume. Then you have to understand what are the confounders for that biomarker to tell you about the circulating volume of your patient. Moving on, urine volume is another parameter that you're going to pay attention to. And if you have a hypertonic patient, you want that urine volume to be low, because if you're conserving water, reclaiming water in the collecting duct, you would predictably see a urine volume that's low, except for the following conditions. Okay, you might see a high urine volume despite a hypernatremic patient or hypertonic patient if I have inadequate ADH or response to ADH, right? This would be a dilute urine, an inappropriately dilute urine in the setting of hypertonicity. That would essentially be central DI or nephrogenic DI. Remember again, I don't want you to get too academic when you use the term nephrogenic DI. I want you to realize that CKD is in some ways a form of nephrogenic DI. You cannot maximally conserve water in that scenario. So I'm using that larger, or I'm using that label to capture a larger set of diseases than you might, think of. You might say, oh, just lithium, nephrogenic DI. No, think of even AKI in some scenarios being a case in which there's inappropriate response to ADH, and that can be labeled as a form of nephrogenic DI. Okay. The other scenario in which I might have a high urine volume, in this case, the urine would be concentrated, right? In this first bullet point, I might have high urine volume without a maximally concentrated urine, that is a low urine osmolality. But in this other class of scenarios, category of scenarios, is when I simply have so many osmoles that I must excrete. Okay, my urine is concentrated, but because I have to dump so many osmoles, whether that be mannitol or uncontrolled hyperglycemia, that would be another scenario in which my urine would be concentrated. Okay, because I'm hypertonic, that glucose is really high, I'm hypertonic, but I'm polyuric, even though my urine is concentrated. right? Glucose urea is driving that polyuria. Right? That'd be a scenario in which I have high urinary osmolar excretions, right? So mannitol will do that. And then the classic is also captured by this final scenario. That is the patient receiving large amounts of nutrition, okay, either parenterally or enterally. If you're giving huge amounts of protein and salt, then you might have a concentrated urine and still be relatively polyuric, even though you would expect a smaller urine volume in somebody who's trying to reclaim all of the water from their urine. Okay? Classic scenario in which we see. All right. Now, finally, fit the urine chemistries to the clinical context. Let me reframe that final statement. I've made this point before. Divorce yourself from the classic scenario that you learned as a medical student and a resident. Dysnatremia, I first assess, is it pseudo hyponatremia or not? And then I do, is my patient hypervolemic or hypovolemic? And then I start to put the urine electrolytes, make sense of the urine electrolytes. So most nephrologists already are biased by the time they see the patient by the urine electrolytes. Your urine electrolytes tell you, is the circulating volume high or low or not low? And then is there an appropriate, or what is ADH doing? Is ADH on or off? And then with that knowledge in hand, I am already seeing a patient with low effective circulating volume. And I get the history and I do the physical and it confirms what I think. I go to the patient with a biased mind. So fit the urine chemistries to that clinical context. This is, again, my editorialization. Urine electrolytes should bias you, and then you go and look at the patient and make it all fit. Okay? All right. Let's then round out this, list of things. So it's unavoidable to go through some lists, but we'll put it into conceptual framework that we built over the last several days. Okay, and then we can talk about some of these individual aspects of the various classic syndromes of hypernatremia. All right, so here's the differential diagnosis of hypernatremia. I'll say in Edelman's terms, that's how I categorize these. So let's go over the first category, the patients that have loss of water in excess of the loss of salt. So these are patients who are clearly hypernatremic. The numerator has shrunk. Classically, this patient is a hypovolemic patient. If I'm hypovolemic, regardless of what my serum sodium is, my numerator in Edelman's is diminished. Okay? But I get hypernatremic because my denominator has shrunk proportionally more than my numerator. Okay? So let's go through examples of this by urine electrolytes biasing me to capture these diagnoses in my lists. Okay? So a patient who has urine osmolality that's high, a urine sodium that's low, you might say, okay, there are two things that are stimulating the reclamation of water. There are two things that are stimulating ADH secretion in this scenario. Number one, well, they're hypertonic. Number two, they're hypovolemic, or they have low effective circulating volume. They may not be hypovolemic per se, but classically, these are going to be your hypovolemic patients, okay? You would expect in these patients that the urine volume is relatively modest. What are examples of this? These are scenarios in which I have extrarenal hypotonic fluid loss. Hypotonic means more water than salt is in this fluid. So if I apply that to this quotient, right? I'm losing more water than salt. I'm losing hypotonic fluids, means the denominator shrinking faster than the numerator? I've already told you that by and large, most of your non-renal outputs are going to be hypotonic, including, for instance, the patient with NG suction. That patient, if they're not taking anything in or getting hypotonic IV fluids back, is going to get hypernatremia because they're losing more water than salt. As this table summarizes, there's few exceptions. Bile losses. We recently had a patient, Kelly and I, who had this biliary drain. It was putting out 4 liters. That patient got hyponatremic because he was losing a fair amount of salt in proportion to the water, even though he was not drinking all that much. Okay. But the other scenarios in general are lost. Pancreatic juices are also hypertonic. But the other scenarios in general are loss of water and excess of salt. And so that patient would predictably get hypernatremic. Okay. Skin losses, especially those patients with burns. Most diarrhea, right? Except for maybe the secretory diarrheas. Vomiting or NG suction. Losses of breath, the water in breath through the ventilatory circuit. Those would be examples of hypotonic fluid losses, extrarenal hypotonic fluid losses. Okay, let's look at a couple of others. Well, what if I have a patient who is not exhibiting the normal urine concentrating response to hypertonicity? You know, I've intentionally made this gray, okay? It would be, you know, abnormal to have a urine osmolality that's 400, okay, in the setting of hypernatremia, right? But that would be something that you could potentially see in a patient who has, for instance, CKD or something, okay? So you want a urine to be very concentrated. So I've just made a lot of things fit into this category. Urine osmolality that's not terribly concentrated. Examples, and then urine sodiums that are not low. Urine volume in this scenario would be relatively high. And so examples of that would be patients who have washout of medullary hypertonicity. Mannitol, we said, can do that. Loop diuretic therapy does that. Bartter syndromes, which is nature's experiment of approximating active loop diuretic therapy. Those would be all patients who you can envision not having this so-called maximally concentrated urine or, you know, semi-maximally concentrated urine. Resolving ATN would be another scenario in which I have, again, patients who have relatively sub-maximally concentrated urine. A resolving obstructive nephropathy would be another scenario in which my urine concentrating mechanism may be impaired, right? These would be scenarios in which I might envision a patient who has, again, loss of water in excess of salt, and they are getting, therefore, hypernatremia. Okay? Now, let's move on. I guess I don't have to belabor the point, even though, well, let me spend a little bit of time just re-emphasizing this phenomenon of resolving obstructive nephropathy resulting in an enhanced water excretion, right? So that's a fairly common scenario that we encounter where somebody who has obstruction relieved, they are polyuric very often in that scenario. Urea is functioning as an effective osmol as it is being delivered to the lumen of the collecting duct. That is impairing that gradient for water reabsorption in the collecting duct, resulting in excess free water loss. So that would be a scenario you can predictably address by ensuring that post-obstructive diuresis is managed with a hypotonic fluid as opposed to giving that patient who's dumping, half a liter an hour normal saline. One would predict you might worsen the hypernatremia in that scenario by giving, isotonic fluids to somebody who's losing hypotonic fluids in their urine. Okay? Let's then move on to those patients who are simply, for the most part, losing denominator. That's loss of water without a deficit of salt. Okay? So what are those scenarios looking like with respect to urine electrolytes? Let's look at the first one. Again, I'm going biased to look at the patient. I'm biased by the urine electrolytes. If I see a patient who has urine osmolality that's quite high, urine sodium that's not low, right? Urine volume that is relatively low, a patient that would fit that would be a patient that had, for instance, primary hypodipsia. Okay? So the urine sodium is going to be variable because let's suppose a hypodipsic patient was also not eating much salt in their diet. They could reasonably have a relatively low urine sodium, right? It's all just what is their circulating volume. So you can imagine that a patient who's not drinking much, right, and also not eating much salt in their diet, if that is the influence that on their physiology, you would expect to see a urine sodium that would be low. Okay, so those things can coexist, right? We'll talk about other things that coexist. For instance, what I would challenge you to sort of think ahead, this will become more relevant in our hyponatremic talk. You classically think of an SIDH patient as someone who has a urine sodium that's not low. But what if an SIDH patient also has heart failure? Those two things can coexist. You should have the agility of mind to expect to see a certain set of urine electrolytes. Don't just get boxed into these, labels and categories. Okay, think about the physiology. Let's go to another row of this table. Urine osmolality that's high. Again, urine sodium that's variable. In this case, my urine volume is relatively high. An example of this would be patients who had those large osmolar loads driving large urine volumes, even though the urine osmolality has been appropriately concentrated in the face of hypertonicity. Here are examples of those osmotic diuretics: high protein diet, glucoseuria from uncontrolled diabetes, or from the use of SGLT2 inhibitors. That would be another scenario that would enhance free water loss in the urine. Okay. Urine osmolality can be inappropriately dilute, or let's say submaximally concentrated. And urine sodium's, again, variable. Variable, it's based on what is the circulating volume of the patient. If the urine osmolality is relatively dilute, you would expect the urine volume to be relatively high. Examples of this would be your classic central DI, nephrogenic DI. Those would be examples that are manifest in these various contexts, right? CNS trauma or CNS surgery. Patients who've had a hypoxemic encephalopathic insult. Obviously, if you have a catastrophic injury to the pituitary, you can have, this is becoming more common actually, patients getting checkpoint inhibitors are sometimes getting this diffuse pituitary insufficiency, hypophysitis, okay, resulting from checkpoint inhibitors, resulting in, hypothyroidism, glucocorticoid deficiency, as well as vasopressin deficiency or central DI. Neurosarcoidosis would be an infiltrative disease. Craniopharyngiomas especially those that undergo surgical resection with some damage to the pituitary. Okay. Subarachnoid hemorrhage, meningoencephalitis are other scenarios that can cause central DI. These are also scenarios in which you can get SIADH, so both sort of physiologies can manifest, as well as the cerebral salt wasting syndromes. So you can see phenomena on both sides from these in these various clinical contexts. There would be genetic possibilities. There's a misfolded vasopressin that can manifest as a familial central diabetes insipidus. And then there are some syndromes that can have as one of their features a central DI. Okay. Nephrogenic DI, the acquired things to be aware of, the electrolyte disturbance that can cause inappropriate response to ADH include profound hypokalemia as well as hypercalcemia. Hypercalcemia is something that we see not infrequently in the, for instance, the cancer wards. These patients can present volume depleted. There's a number of factors that hypercalcemia can cause to result in hypovolemia. The nausea of hypercalcemia is one. The natriuresis of hypercalcemia is another. We'll talk about that when we talk about K-wasting syndromes like Barter's. To anticipate that, an activating mutation of the calcium sensing receptor is one form of Barter's. So hypercalcemia can approximate a Barter's phenotype. And then also the nephrogenic DI, the water loss that can result from profound hypercalcemia. Drugs, including lithium, is a classic one. Demeclocycline is on the list. You'll find that that's very rare. I don't think many people use that anymore, especially with more tools to manage impaired water excretion, like urea tablets. People are using that much more, and SGLT2 inhibitors. Amphotericin can cause us nephrogenic DI, as can foscarnet, vasopressin antagonist. I'll also add, there is the platinum drugs that can also cause a mild impairment in urinary concentration. Any chronic tubular injury, including CKD, would be a scenario again in which you cannot maximally concentrate urine. So it'd be reasonable to consider that as a form of nephrogenic DI. Sickle cell disease is a phenomenon or a syndrome in which there are a number of renal manifestations, including proteinuria from secondary or adaptive FSGS. You can have an hyperkalemic RTA. You can have relatively low uric acid levels. You can have hyperphosphatemia, and then you can also have a diabetes insipidus. So I'm just throwing a lot at the wall, of course, on that, just to say, stay tuned. Think about sickle cell disease, because a nephrologist is going to manage a number of complications of sickle cell disease, one of which can be a nephrogenic DI, but there are others. RTA, high serum phos, proteinuria, all of that we'll cover. Okay? There are mutations or genetic defects that can result in diabetes insipidus as well, which I've cataloged in that list. And then vasopressinase would be a form of diabetes insipidus as well that can happen during pregnancies. Pregnancy can cause diabetes insipidus through pituitary apoplexy, classic scenario in which pituitary insufficiency can occur. And there also can be placental vasopressinase, cleaving vasopressin, resulting in a form of diabetes insipidus as well. Okay, that classically can respond to DDAVP. that placental vasopressinase cannot cleave the pharmacologic analog of vasopressin that is DDAP. All right, let's go through another category. These are patients who gain sodium in excess of water. So in Edelman's terms, the numerator has expanded beyond the denominator. So what would be examples of these? Well, if you as a provider give large amounts of hypertonic saline, either through 3% saline itself, or you're giving multiple amps of sodium bicarbonate to the crashing and burning ICU patient, that would be a scenario where one can envision these are predominantly the numerator is expanded more so than the denominator, right? You're giving lots of salt with very modest amounts of water. So you should add to this, getting over aggressive with Bicitra. Bicitra is another very hypertonic solution. It's a lot of salt without much water. Okay. So that would be captured by this kind of very large salt load, Bicitra. Okay. Administration of isotonic fluids with hypotonic fluid losses that are non-renal. Okay. So this would be, again, that patient who has, a burn and they're losing hypotonic fluids, but you're giving lots of isotonic fluids. The patient who's having lots of diarrhea or vomiting, respiratory water loss. This is a lot of the patients. This captures a lot of those patients in the ICU that you see. So a lot of those ICU patients who are, classically, they often have capillary leak, their volume expanded, they're hypernatremic because they're getting a bunch of carrier IV fluids or IV fluids from the provider, and they're losing hypotonic fluid through their rectal tube or through a weeping, leg wound. And so they get progressively hypernatremic. So these are patients again, this phenotype is in large part a lot of those ICU patients that are getting isotonic fluids, but have extrarenal hypotonic fluid losses in the respiratory circuit, etc. So the urine electrolytes are going to be captured by this set. Urine is going to be concentrated because they're hypertonic. Their urine sodium will be variable according to their circulating volume, and their urine volume will be relatively modest. Okay? Those patients that have submaximal urine concentration, urine sodiums that are relatively high with large urine volumes, this would be a patient who had, for instance, mineralocorticoid excess. Let's talk about that briefly. Remember, we talked about this, that when you're chronically volume expanded, as you might expect in hyperaldosteronism, you can have a reset osmostat, right? The most common reset osmostat is one in which you get hyponatremia. Scenarios in which you'll have reset osmostat and hyponatremia, the most common is going to be your pregnant female. That will be a form of reset osmostat to a lower set point of serum sodium. But in volume expanded states like hyperaldosteronism, there appears to be a reset osmostat of sorts in order to defend against the hypervolemia. There is, let's say, an adaptive elimination of water, and so the sodium is relatively high in these patients that might have this chronic hyperaldosteronism. These others are basically forms of mineralocorticoid excess, much less common than hyperaldosteronism. We'll talk about these as we address, we did talk about it at the end of our last academic year and covered secondary hypertension. We'll also touch base on these diagnoses as we shift over to hypokalemia. Okay, so keep this in mind. Mineralocorticoid independent sodium retention would be captured by these other scenarios. Cushing's disease is a scenario in which I have obviously excess cortisol. Cortisol is binding the mineralocorticoid receptor and is functioning like or is approximating a state of hyperaldosteronism. We'll talk about these others in our discussion on dysnatremia. These are scenarios in which they often look like primary hyperaldosteronism, but aldosterone is not in excess. You know, for instance, with Cushing's, cortisol is activating the mineralocorticoid receptor in a apparent mineralocorticoid excess. We have a problem with deactivating cortisol at the tissue level. So again, cortisol is activating the mineralocorticoid receptor. And then there are others. Little syndrome may be the most digestible, you know, to sort of plant a seed, and then we'll cultivate it in our dyskalemia discussion. This is an activating mutation or a mutation that results in constitutively activated ENaC. Okay, so that would look like a hyperaldosterone patient. Okay, these patients are volume expanded, even though they have relatively high mineralocorticoid activity. You would still expect that their urine sodium is not going to be conserved because they're volume expanded in net. And so, for instance, proximal tubular sodium transport is downregulated. So even though you might sort of anticipate, if I have a mineralocorticoid excess, I would presumably have a low urine sodium. That is not the case, because in other segments of the nephron, that volume expansion has decreased sodium reclamation, most prominently in the proximal tubule. The net effect is urine sodiums that are not low in these patients with mineralocorticoids excess. Okay, so finally, shift of water into the intracellular space. These would be patients by total body parameters of salt and water balance have no problem with total body content of salt and water. It is simply water that is shifted into the cells. This can happen when you have massive muscular contraction, and that results in a transient increase in osmolality of the muscle cells. And examples like intensive exercise or grand mal seizures would be examples of this. Rhabdo patients are predisposed to a water shift into cells by releasing some of these osmotically active particles from injured muscle tissue. These patients develop those compartment syndromes, or can develop compartment syndrome from this rush of water into damaged tissues. They can also develop hypernatremia as water moves into some of these damaged tissues, muscular tissue. Okay, urine osmolality would be variable, as would urine sodium and urine volume in these scenarios. Okay, let's then go into some of these individual syndromes and talk about some of the nuance of these syndromes, including in some cases treatment. So diabetes insipidus we'll talk about first. This can obviously be central and nephrogenic, which we've covered. The presentations by urine chemistries we've covered. We don't need to belabor this. So patients with diabetes insipidus do not present with hypernatremia. I made that point before, I'm emphasizing it again. They present with polydipsia and polyuria. So let's just reiterate that if somebody is hypernatremic, we already stated somewhere in here that this is a patient, if you're hypernatremic, you must have a problem with your thirst response. Okay, that is something that we covered. Yeah, the pragmatic evaluation of hypernatremia. Step one, if you're hypernatremic, that means there's something wrong with your ability to respond to that hypernatremia, because Otherwise, you would drink. So again, patients with DI, without and with an intact thirst response are not hypernatremic. They are simply polydipsic and polyuric. Okay. How do you discriminate this patient from a patient with polydipsia because of a compulsive water drinking? Well, you can do that, of course, through measuring urine osmolality. Okay. So if you have a patient who is already hypernatremic, right? This patient cannot be a primary polydipsic patient, right? If you're drinking a lot, you can't have, a serum sodium and measured osmolality that's in excess in a patient who's primary polydipsic, right? They would be predictably having low to normal sodiums. So if you measure it as a first step, serum osmolality and serum sodium, and they are hypernatremic, obviously out the gate, you could say, well, this is clearly this polydipsic or polyuric patient is not a case of primary polydipsia, right? So we can then move, we don't have to do much else, okay? Now, if I have a patient who doesn't have that more obvious example of diabetes insipidus, then we can start measuring things like urine osmolality and not sure what I said leading into this. Again, if it's not clearly a case of primary polydipsia and you're now considering diabetes insipidus as a diagnosis, measuring urine osmolality would be how you can figure out whether this is, again, central DI or nephrogenic DI, okay? Obviously, if my urine is concentrated, it's not diabetes insipidus. So this patient who is claiming polyuria with a concentrated urine, sometimes you'll get these consults of patients, gosh, I pee so much at night. Do I have a problem with my kidneys? And then you'll, check urine osmolality at a first morning void, and you'll say, no, there's no problem with your kidneys concentrating urine. This is just, it's not something that is obviously explainable. Okay, you have this subjective sense of polyuria, but your kidneys don't appear to be manifesting this. Okay. Now, of course, if I have a urine osmolality, which is not maximally concentrated, that's when I'm considering a patient might have diabetes insipidus. We may want to consider DDABP to discriminate whether this is central or nephrogenic. Here's a protocol that one might use, okay? And then a patient will be evaluated based on their response in urine osmolality to that exogenously administered desmopressin. So if I have a urine osmolality that doesn't concentrate much at all, obviously that patient has a profound nephrogenic diabetes insipidus. Okay, so I start with a urine osmolality that's dilute and it doesn't concentrate in response to desmopressin. If I have a patient who has some response, right, but the response is submaximal, then you can claim that this is a partial nephrogenic diabetes insipidus. Obviously, if I have a problem with central DI or this placental vasopressinase, giving desmopressin would result in a very robust response to that manipulation as exhibited by a concentrated urine in that 600 or higher range. Okay. Now, if I have a patient who has relatively normal serum osmolality and serum sodium, that's when I have to consider the differential. Is this polyuric patient simply drinking too much, or do they have a patient? Is this a patient with diabetes insipidus who's responding with a normal thirst response? Okay, so How do we discriminate between those? You can do a water deprivation test or make them hypernatremic through the administration of hypertonic saline, right? So I can restrict free water, often from an overnight fast, and then I check their urine osmolality as well as their serum osmolality. I confirm that their serum osmolality has risen a bit over that overnight fast. And if they are not concentrating their urine, then that would be a patient who, if they're not concentrating urine, then that would be a patient who might have these syndromes of diabetes insipidus, which you can elucidate with DDAVP. If, on the other hand, they have the normal concentrating response, then this is a patient who's simply drinking too much as an explanation for their polyuric complaint. Let's then, cover this triphasic diabetes insipidus syndrome that we occasionally see. This is something that is classic in a patient who has a CNS trauma or a pituitary surgery. So classic transsphenoidal parathyroid or pituitary adenoma resection would be a scenario in which you can get this triphasic diabetes insipidus syndrome. This is manifest in, as the name implies, 3 different phases. So first off, I have polyuria from this central diabetes insipidus, okay? So if I were to draw this out for you, again, I have my pituitary stalk. I may have something that disrupts this hypothalamic pituitary stalk. And then the first response is sort of a shock and a inadequate release of vasopressin from the secretory granules in the pituitary, right? So I get an initial problem with concentrating my urine. I'm initially polyuric, right? Now I get this syndrome of ADH or inappropriately excess ADH. And this is because this pituitary stalk, which has been disrupted, remember, these secretory granules are derived from neurons that exist in the hypothalamus, in the posterior wall of the third ventricle. And so as I transect these cell processes, I may get degeneration of some of these secretory apparati, and therefore I start to get this inappropriate release of ADH from those dying neurons that are transported vasopressin to the posterior pituitary. So I get that second phase of this triphasic diabetes insipidus. And then comes the chronic phase. As this is exhausted, I'm no longer having any preformed vasopressin to release, and now I have the vasopressin deficiency that is manifest in the chronic phase as a diabetes insipidus. Okay, now this is not always manifest. You may have some of these early phases, but not have the full expression of diabetes insipidus later on, because you need a fairly dense injury to these cells in order to manifest this deficiency of vasopressin in this classic triphasic diabetes insipidus.